Κυρίες και κύριοι, καλησπέρα σας. Είμαι ο συνταγματάρχης ιατρός Παναγιώτου Ιωάννης. Είμαι επιμελητής της Διακλαδικής Καρδιοχειρουργικής Κλινικής των Ενόπλων Δυνάμεων Αποκτήσεως από το 2013 και είναι ιδιαίτερη χαρά και τιμή μου να βρίσκομαι από τη θέση του Προεδρείου στο δεύτερο μάθημα του δεύτερου κύκλου των μαθημάτων της Εξωσωματικής Κυκλοφορίας που διοργανώνει η Διακλαδική Καρδιοχειρουργική Κλινική. Έχω επίσης τη χαρά να έχω αριστερά μου και δεξιά μου δύο εξέχοντες επιστήμονες, τον κύριο Μπόμπο Δημήτριο, Διευθυντή του Καρδιοχειρουργικού Τμήματος Παιδών και Συγγενών Καρδιοπαθειών από το Άσιο Καρδιοχειρουργικό Κέντρο και τον κύριο Νικόλαο Θεοδοσιάδη, Ειδικό Εξωσωματικής και Επιμελητή του Τμήματος της Εξωσωματικής Κυκλοφορίας της Διακλαδικής Καρδιοχειρουργικής Κλινικής των Ενόπλων Δυνάμεων. Θέλω να μου δώσετε 2 λεπτά να εκφράσω 2 σκέψεις σχετικά με το θέμα, με τη θεματολογία του σημερινού μαθήματος. Το θέμα είναι η χειρουργική αντιμετώπιση των συγγενών καρδιοπαθειών. Είναι γνωστό ότι η παιδοκαρδιοχειρουργική και ιδιαίτερα η διόρθωση των συγγενών καρδιοπαθειών σε νεογνά και βρέφη έχει κάνει άλματα, τεράστια άλματα τις τελευταίες δεκαετίες. Είναι εύκολα αντιληπτό ότι όσοι ασχολούνται με τους μικρούς ασθενείς οφείλουν όχι μόνο να γνωρίζουν τα της καρδιάς, αλλά και όλα τα υπόλοιπα οργανικά συστήματα σε κάθε στάδιο της ανάπτυξής τους, σε κάθε ηλικιακή ομάδα. Είναι αυτονόητο ότι τα υλικά που χρησιμοποιούνται στα κυκλώματα εξωσωματικής κυκλοφορίας διαφέρουν από αυτά που χρησιμοποιούνται στους ενήλικες, τόσο στο μέγεθος αλλά και στις προδιαγραφές. Είναι πολύ σημαντικό να κατανοήσουμε ότι τα βρέφη και τα νεογνά δεν είναι μικρόσωμοι ή μικροσκοπικοί ενήλικες. Είναι εντελώς διαφορετικές οντότητες που θέλουν διαφορετικό χειρισμό. Επιπλέον, αν και τα παιδιά είναι ευαίσθητα από πολλές απόψεις στην ισχαιμία και στην επαναιμάτωση, ταυτόχρονα η κατάσταση της ανοριμότητάς τους επιτρέπει να έχουν εύκολη και πολλές φορές εντυπωσιακή ανάρρωση μετά από βαρύτατες καρδιοχειρουργικές επεμβάσεις. Θα συνεχίσουμε με τον πρώτο ομιλητή. Ο κύριος Χατσίσκι νομίζω απουσιάζει. Ωραία. Οπότε θα προχωρήσουμε στον κύριο Πουλή, Ειδικό Εξωσωματικής Κυκλοφορίας από το Άσιο Καρδιοχειρουργικό Κέντρο, ο οποίος θα μας αναπτύξει το θέμα Blood Management in Pediatric Cardiac Bypass, Strategies for Improving Outcomes in Children. Παρακαλώ, κύριε Πουλή, έχετε το λόγο.
Τώρα, ωραία. Καλησπέρα και από μένα. Να ευχαριστήσω την Οργανωτική Επιτροπή, το διακλαδικό τμήμα της καρδιοχειρουργικής, τον κύριο Κοτούλα ιδιαίτερα και τους φίλους εξωσωματιστές για την πρόσκληση που μας απευθύνανε να συμμετάσχουμε σε αυτή την ιδιαίτερη και πρωτοποριακή σειρά κλινικών μαθημάτων για την εξωσωματική κυκλοφορία. Είναι ιδιαίτερη χαρά, ιδιαίτερα σήμερα, γιατί για πρώτη φορά μοριοδοτείται από το EBCP μια τέτοια προσπάθεια. Οπότε η παρουσίαση θα είναι στα αγγλικά. Θα κάνουμε μια αλλαγή τώρα, λοιπόν, της γλώσσας και οφείλω βέβαια να συστηθώ και στους φίλους που θα μας παρακολουθούν από το διαδίκτυο. So, my name is Dimitrios Poulis. I am a clinical perfusionist at Onassis Cardiac Surgery Center of Athens. My presentation is about blood management in pediatric cardiac bypass, and to talk about strategies for improving outcomes in children. Why children? Because they face unique challenges, especially neonates and infants. The cardiac bypass is often necessary in congenital heart disease repairs. The effective blood management is crucial to minimize complications and improve surgical outcomes. When we talk about blood management, we talk about red blood cells, frozen plasma, platelets. Just a short look about the numbers of congenital cases in Europe. The European Society of Cardiology reported an average of 36.77 congenital cardiac surgeries per million people across Europe. This means 27,000 cases per year. And in each case, we need 1 to 5 units of red blood cells, and the main cost in Europe of €800 per unit, of course. This means a huge number. We talk from the beginning for unique challenge because of the differences from adults. Smaller blood volume, immature immune and coagulation system, increased risk of hemodilution, coagulopathy, and hypothermia. Pediatric patients, especially infants, have smaller blood volume compared to adults. This makes them more sensitive to hemodilution during cardiac bypass surgery, where the patient's blood is diluted with a prime solution used to fill the heart-lung machine. The immune and coagulation system are not fully developed, increased risk of infection, delayed good healing, sensitivity to blood products. The exposure to the foreign surface of the circulation of the cardiopulmonary bypass circuit can activate the coagulation system, leading to consumption of clotting factors and platelets. This can further exacerbate bleeding tendencies. Children have a large surface area to body mass ratio, making them more prone to heat loss. The immature thermoregulator system in infants and young children is less effective at maintaining body temperature. Just to have an image about the circuit volume and the blood volume of a child, for example, for a child of 1 year, 7 kilograms, where he has 500 milliliters of blood volume, and the circulation system needs for prime at least 300 milliliters. This means 60% for a child, when for an adult it's only 30%. Our primary goals: minimize blood transfusions, prevent coagulopathy, and reduce the risk of bleeding, maintain oxygen delivery and organ perfusion, reduce postoperative complication, engage recovery rates, and reduce ICU stays. The risk factor that we faced: hemodilution due to cardiopulmonary bypass prime, cardioplegia, and administration of fluids in the perioperative period, activation of coagulation and fibrinolysis, and consumptive coagulopathy, anticoagulation using unfractionated heparin, as well as other psychological disturbances, hypothermia, acidemia, hypocalcemia. 2018, Hollet, Siemens, and other authors has put some important pillars: the effort to optimize preoperative hemoglobin, limit blood sampling, improve hemostasis, reduce bleeding, correct coagulopathy, and incorporate blood-sparing techniques are important pillars of patient blood management programs. A 2019 published NATA guidelines, patients' blood management for neonates and children undergoing cardiac surgery. Before we go to continue at the perioperative time, let's have a short look at preoperative optimization. One of the cornerstones of modern blood management programs is identification and the treatment of preoperative anemia, correct anemia with iron or erythropoietin. In a single-center retrospective cohort of 220 children undergoing cardiac surgery, preoperative anemia was associated with an increased risk of perioperative acute kidney injury. Therefore, treatment of preoperative anemia appears important to decrease perioperative anemia-induced complications and blood transfusions. Use of autologous blood donation, of course, when it's possible. Pharmacological interventions. Antifibrinolytic agents include aprotinin, a serine protease with multiple effects, but most notably working as direct plasmin inhibitor, and the lysine analogs, the most common tranexamic acid. Let's go now to the techniques during surgery. Hemodilution minimization. Use pediatric size bypass circuits. Use of hemoconcentration techniques. Minimize prime. Cell salvage, modified ultrafiltration. Let's go now to see one by one. One potential target unique to neonates and small infants when compared to adults is the enormously disproportionately large cardiopulmonary bypass surface area with respect to patient size. Circuit miniaturization allows this ratio more in line with that of older children. Clinical models suggest that these efforts could reduce fragmentation of blood cells and large proteins. Investigation also suggests that avoiding the use of allogenic blood in the PAP prime, which can be achieved if the circuit size is adequately restricted, may significantly reduce CPB-induced inflammation and coagulopathy. When for an adult half arterial line and circuits 3/8 and the venous lines of half, for a pediatric, for a child we have 3/16 or 1/4 arterial line and 1/4 venous. The length of circuit is almost for an adult 6 meters, and in a pediatric case, around 3 meters. And of course, at the pediatric cases, pumps as close as to patient reservoir. Let's talk about prime. Using a modified cardiopulmonary bypass setup in 13 consecutive neonates, less 28 days old, Kosten et al. Were able to reduce the total CPB priming volume from 200 milliliters to 110 milliliters. CPB circuit was minimized to a priming volume of 73 milliliters for the smallest patients with body weight up to 2.5 kilograms and 85 to 95 milliliters for those with body weight of more than 2.5 kilograms. Many authors concluded that fresh frozen plasma in the priming solution for infants appears slightly superior to late administration in terms of postoperative bleeding. When a clear prime is preferred, different crystalloids like Ringer's lactate, plasmalite, or colloid, albumin, etc., solutions are available. Authors conclude that albumin is expensive, but is better primed to maintain hemostasis, colloid oncotic pressure, and reduce blood products requirements. Ultrafiltration. We have two ways. Conventional ultrafiltrations performed during CPB in children associated with a statistically significant but clinically modest increase in the concentration of fibrinogen and other coagulation factors at the end of the procedure. Modified ultrafiltration, which is performed after weaning from CPB, has been demonstrated to increase plasma protein concentration and decrease postoperative bleeding and transfusion requirements. The efficacy of the two techniques have been discussed in several articles. These findings suggested that both modified ultrafiltration and conventional ultrafiltration can improve clinical condition in the immediate post-cardiopulmonary bypass period, reduce the plasmatic concentration of inflammatory molecules, increase plasma protein concentration, and decrease postoperative bleeding and transfusion requirements, improve pulmonary compliance and gas exchange. Recent technical advances have made cell salvage feasible in neonates and infants, and therefore the use of cell salvage devices in pediatric cardiac surgery is now more common. Acute normovolemic hemodilution involves the removal of blood, mostly shortly after the induction of anesthesia, and is simultaneously replacement by an adequate volume of colloid or crystalloids to maintain normovolemic status. The efficacy of NaH depends on several factors: the volume of surgical blood loss, patient's initial hematocrit, target post-NaH hematocrit, and the hematocrit used as the transfusion trigger. The size of the patient, but also starting hematocrit, cardiac anatomy, and whether a lesion is cyanotic or not cyanotic will impact not only the safety of the procedure, but also its successful completion. There are studies suggested that children with an CPB hematocrit of 20% had a worse outcome than those with an CPB hematocrit of 28%. The administration of 400 units per kilogram of heparin has been shown to produce adequately prolonged activate clonic time above 480 seconds in infants and children. However, to the low levels of adithrovine in neonates, the standard weight-based doses have been shown to inadequately suppress thrombin generation. Indeed, the differences in heparin sensitivity in the pediatric population is likely to be related to adithrovine levels. And as adithrovine is produced by the liver, it is influenced by age, heart failure, liver dysfunction, and inflammation. If we like to sum up all the previous slides, and to create recommendations we talk about. Diagnosis and treatment of preoperative iron deficiency anemia. Prophylactic administration of lysine analogs. Miniaturized cardiopulmonary bypass for neonates and infants in order to reduce the effects of hemodilution. A target hematocrit above of 24% during cardiopulmonary bypass. Fresh frozen plasma to the CPB prime in neonates. Colloid albumini should be preferred over crystalloids for clear priming. Conventional ultrafiltration, or at least 10 minutes of modified ultrafiltration for neonates and infants undergoing cardiac surgery. Use of cell salvage in pediatric cardiac surgery in order to reduce perioperative transfusion and targeting ACT 480 before and throughout CPB, and initial dose of 400 units per kilograms of unfractionated heparin prior to CPB initiation. We begin with challenges in implementing blood management protocols. Challenges because it's difficult predicting blood loss in complex cases, variability in coagulation response in children, equipment limitation in smaller children. The solution in all this, multidisciplinary team approach, ongoing training, and of course, protocol adjustments. This is the only way to drive to the success. And the benefits of a blood management in pediatric cardiac surgery is to reduce infection risk from fewer transfusions, shortened ICU stays and faster recovery, lower rates of transfusion-related complications, lower overall healthcare costs. Thanks for your attention. Σας ευχαριστώ.
Dimitris, thank you very much for your precise and understandable presentation. I would like to invite Mr. Saris for a short comment. Mr. Kanakis, please, you have the floor.
Στα αγγλικά το... Very nice presentation, Dimitris. You explained everything. What should we focus on, especially on pediatric and neonatal circuit? I would like to stress that we prefer the smallest circuit with the highest flow. This is the purpose. And of course, MAF, now only MAF, not conventional ultrafiltration, MAF, and in some cases, especially in the USA, zero balanced ultrafiltration, but there are no trials comparing those MAF and ZBAF. So MAF or ZBAF is zero balanced ultrafiltration is probably the same, but you should be very careful because you are doing this at the end of the procedure, and you need to be very aware of air embolization and all these things. And of course, surgical technique. You should be meticulous, not to have that afterwards in ICU, I mean. And just to let you know that modified ultrafiltration has not proven the superiority in ICU stay and hospital stay.
Thank you very much. We have online Mr. George Saris, Chief and Director of Second Pediatric Cardiac Surgery of Mitera Clinic, for a short comment, please.
I would like to congratulate the speaker for a very nice overview of the problems, the challenges, and recommended actions to improve outcomes when using cardiopulmonary bypass for neonates and small infants and children. Obviously, it was covered well. My comment is that many of these interventions can be used and adopted to different degrees. It is very important, as I think the speaker already suggested, that they all be fitted into a whole system that is used consistently in a protocol manner, so that results, successes, and problems can undergo scrutiny and troubleshooting. And in the end, different units use very successfully various permutations of these protocols, even if individual components may differ, and that pertains to many parameters. There are many details, which of course a short presentation could not have possibly covered, and many issues. For example, what one does when there is consideration of the use of aprotinine in cases of circulatory arrest. There are issues of how to compose the prime. For practical reasons, reconstituted blood prime is what is used, but there are instances, and there is evidence that whole blood, which is really not available, may be superior. There are other issues like the potential use of removal of white cells, so leukocyte depletion may be helpful. The use of steroids in the cardiopulmonary bypass prime as one of many measures to address systemic inflammatory syndrome, which can be sometimes very severe in neonates, and many others. But on the whole, as I said, the presentation touched on the most important components, and I would just reiterate that it's important that all these components be thought of as a package of measures that should be used consistently in a protocol, and then each team, according to local practice and local availability of technology, can try to adapt and improve this whole package by monitoring results and improving on potential problems. Again, congratulations for the very nice presentation.
Thank you, Mr. Saris. Is there any question or a short comment from the audience? Okay, so we have to continue. Nikos, please address the next guest.
Okay, Mr. Kodziski. No. Okay.
Μπορούμε να προχωρήσουμε στον επόμενο μιλητή, που είναι ο κύριος Φώτης Μητρόπουλος, που είναι διευθυντής της πρώτης καρδιοχειρουργικής παιδών και ενηλίκων συγγενών καρδιοπαθειών στο Μητέρα. Μεγάλη μας τιμή που παρευρίσκεται εδώ και παρακαλώ να προσέλθει για την παρουσίαση.
Θα είναι, απλώς είναι noise ακόμα. Όχι, υποτίθεται ότι ξεκινάει σε 20 λεπτά. Όντας.
Ο Άλεξ Ρόμπερτσον είναι απασχολημένος, κάτι έχει συμβεί με το connection και είναι σε έκμο. Είναι σε μια διαδικασία, έχουν κάποιο πρόβλημα.
Μας είπε ότι αν
πολύ
προλάβει...
πιθανόν αν προλάβει και εντάξει, τον λυπεί το γεγονός, αλλά έχει αυτό το θέμα. πρώτα με τη σύνδεση και δεύτερον προέκυψε κάτι επίγον, αλλά στο τέλος μπορεί να
έστειλε μήνυμα ότι είχε πρόβλημα, δεν μπορούσε να συνδεθεί και μετά λέει αν προλάβω, του είχε ένα έκμο και ότι αν προλάβει μετά
θα παρουσιάσει.
Ορίστε.
Η ενδοσκοπική καρδιοχειρουργική στην αντιμετώπιση των συγγενών καρδιοπαθειών θα την παρουσιάσει ο κύριος Φώτης Μητρόπουλος. Είναι διευθυντής της πρώτης καρδιοχειρουργικής κλινικής παιδών και ενηλίκων στο νοσοκομείο Μητέρα. Φώτη.
Σας ευχαριστώ θερμά, αγαπητό Προεδρείο, κύριε Κοτούλα, κύριε Θεοδοσιάδη και οι συνάδελφοι τεχνικοί Εξωσωματικής που να τους συγχαρούμε για την προσπάθειά τους για συνεχιζόμενη εκπαίδευση και ευχαριστώ για την τιμητική πρόσκληση. Το θέμα που μου ανατέθηκε έχει να κάνει με την ενδοσκοπική αντιμετώπιση των συγγενών καρδιοπαθειών και θα σας δείξω λίγο κάποια από τα δεδομένα. Η ενδοσκοπική καρδιοχειρουργική σίγουρα δεν είναι κάτι καινούριο. Εάν κάποιος δει ποιες είναι οι βιβλιογραφικές αναφορές τα τελευταία χρόνια, συνεχώς πληθαίνουν. Οι μεμονωμένες αναφορές που αφορούν για την παιδιατρική και ενδοσκοπική καρδιοχειρουργική συγγενών καρδιοπαθειών είναι λίγες και τα επίσημα επιστημονικά δεδομένα όσον αφορά την σύγκριση μεταξύ αυτής της τεχνικής και της συμβατικής δεν υπάρχουν ακόμα. Η φιλοσοφία στην καρδιοχειρουργική, στη χειρουργική, στην παιδοκαρδιοχειρουργική είναι η ελαχιστοποίηση του χειρουργικού τραύματος. Ναι, καλύτερα. Okay. I apologize. Let me just rephrase. The first slides had to do with how many, what are the available scientific data on endoscopic cardiac and endoscopic pediatric and congenital cardiac surgery. Over the course of the past decades, we have been evolving into a less invasive approach, and it's not something new. The first idea came around the mid to late 90s from the Stanford group, and this process has been very, very, very slowly advancing. The idea and the technique has evolved from sternotomy to incisions and then subsequently to ports. And I think that's where we are right now, both in the field of adult and pediatric surgery. The feasibility, the safety, and short-term outcome has been documented in few reports in the literature and is gaining more wide approach. This is a paper that was published in 2015 and compared two minimal invasive approaches, the totally endoscopic and the right anterolateral, and has proven that they both provide excellent cosmetic and functional results, and that the totally thoracoscopic or endoscopic has much lower incision, as well as a much better result and patient satisfaction. The one group from China has even reported back in the almost 12, 13 years ago, something that at that point was almost unheard, thoracoscopic closure of ventricular septal defects. And even their patients did quite well based upon the study that they published, and they concluded that thoracoscopic closure of VSD is feasible and safe. We have embarked into the program of becoming capable in performing endoscopic cardiac surgery by a series of steps that we have followed. We affiliated ourselves with one of the most advanced and older programs performing endoscopic cardiac surgery in adults from Italy. This program provide us with the initial visitation in their hospital so that we can see their setup. And in the following years, they have been proctoring us performing cases on a monthly basis. Initially, we started with acquired cardiac surgery cases, and then as we gained more experience and we became more capable in doing these cases, we proceeded to the endoscopic. Our numbers have been growing steadily. We have experience with over 300 endoscopic cardiac cases. In our initial experience, we had one conversion to sternotomy, 4 deaths all acquired, 1 early reoperation. The older patients we have operated is 93 years old, the younger 5 years old, and the smallest only 12 kilos. The adult cases, the numbers are these. And this is the slide that contains our experience with the congenital cases. In the beginning, we were doing mostly secundumous ASDs, but over the course of the years, we have been able to perform even more complex cases. We've done sinus venosus, totally right-sided PVR, subaortic membranes, ostium primum defect, 2 cases of ventricular septal defect, 2 cases of DCRV. We have done 2 pediatric cardiac tumor resections, aortic valve replacement for bicuspid aortic valve, mitral repairs, mitral replacement, and tricuspid. The protocol that we follow is general trachea anesthesia, central venous access, peripheral arterial invasive blood pressure monitoring, CNS monitor, NIRS, and EEG monitoring, defibrillator patches on all the patients so that we defibrillate if we need to, regional anesthesia catheter for block so that the patients don't have pain in the postoperative period, fast track extubations. So we have at least 12, maybe more than 12 pediatric patients that have been extubated in the operating room, POC, point of monitoring of the coagulation, and transesophageal echocardiography. Those are the times. For the most part, those procedures are lengthier and it takes more than to do them compared to the conventional sternotomy. But it pays back when it has to do when you compare it with the outcome, since patients stay less in the intensive care unit and they recover much faster. The need for transfusion is much less. For pediatric patients, we're down to 20-25% transfusion rate, which is much less that you would expect. Complications, of course, we have, and we had one case of reoperation for endocarditis, one patient with SVC stenosis after sinus venosus repair that Dr. Jifa was kind enough to fix that for us. Pleural effusion is not an uncommon thing. We had no vascular complications and no death. The surgical technique, we make a transverse incision in the inguinal region and we dissect the vessels, and we use the femoral technique to obtain access in the femoral artery and vein. We inflate the surgical field with carbon dioxide. We use one camera port along the anterior axillary line and a second one for a working port. And typically we make a circumareolar incision that aesthetically is afterwards something very, very satisfying. We open the pericardium on the right side, cephalad to the phrenic nerve, about 2 to 3 centimeters, and we put pericardial stitches and we retract them. Since this is organized by the perfusionist, we go into some details as to the systems that we're using. The protocol we use for 10 to 18 kilos is quarter-inch tubing arterial, quarter-inch venous. For 18 to 30 kilos, quarter-inch arterial 3/8 venous. And for the bigger children, 30 to 55, 3/8, 3/8. For the arterial access, anything from 12 to 18 for the artery, and the venous 15 to 23, double stage. And if we need to do something intracardiac, we put another one in the superior vena cava versus the internal jugular. We have the anesthesiologist put a catheter in the beginning, and then we prep in our field, and subsequently we exchange that over wire to another cannula. Usually we put a femoral 14 or 17 in the IJ. The cardioplegia technique we use is the delineator cardioplegia, and we administer that about 30 ml per kilo at 4 degrees Celsius. We cool the patient to 32 degrees, and if it's more demanding procedure, we go even further down, because we believe that part of the myocardial protection is very important. One of the setups you can see here, the cannula in the IJ and the second and the other cannulas in the femoral before we start. For a typical ASD closure, we do it the same way that we do it in open technique, open the right atrium, and if we add a suture, close it or put a patch. We have performed the first endoscopic pediatric case in Greece. This is one of the cases that you have a sizable ASD. This is the image you see on the other side is the vent. The image that we have is very, very anatomic and very clear. This is the postoperative result on a girl that we've performed a quadrilateral sinister repair. You can see the aesthetic result afterwards, the periorbital incision and the 2 side ports. Another case with secundum ASD that we use a patch, and this is the immediate postoperative period. When we do the thoracoscopic AVR, this is the incision that we see. We have performed also on some even more complicated cases as we gain more experience. This is a case of a 20-year-old male with a history of infantile coarctation repair via a left thoracotomy, followed by percutaneous balloon angioplasty, then a median sternotomy for arch reconstruction, and then develop a severe MR with a dilated left ventricle and bileaflet prolapse. You can see the mitral valve. And you can see the result afterwards with chordal implantation and ring. This is the left thoracotomy incision that he had in the past. This is the median sternotomy, and this is the third procedure that we've done of thoracoscopic repair via a periareolar incision. The advantages of this technique are as follows: less injury to the patient tissue and anatomy, minimized blood loss and the need for transfusion, almost zero rates of intraoperative or postoperative infections because the incisions are so small, shorter patient stay in the intensive care unit and shorter hospitalization, faster recovery and mobilization. The postoperative pain with the protocol, the anesthesia protocol with our experienced anesthesiologist is of a great value, very low reoperation rate, and it is very impressive what the patients and the family tell us about the aesthetic result and the psychological result. Usually, typically this technique is a technique that it requires skills both emotionally, psychologically, and technically. You have to be able to, at least in the beginning, be able to identify which patients are capable, best for this technique. The training, there's no doubt that this is a technique that has a steep learning curve. So for sure you need some help and some assistance and some guidance in the beginning, and not only in the beginning. You obviously need specialized equipment and maintenance procedure. There are some disadvantages, as the longer time of anesthesia, surgery, cardiopulmonary bypass, and cross-clamp time. It has not been a major problem. The theoretical risk of the small femoral vessels with experience, we haven't had any of those. The cost, for sure, it requires some initial investment as far as getting the right setup, and we need to follow up on these patients so that we can see the long-term outcome. Those are some more cases. I'm not going to bother you. This is a physician ophthalmologist that had a sinus venosus repair with a two-parts technique, and this is the postoperative result on him. This is a patient of Dr. Jifa that I will show you in a moment that would fix a DCRV. And if you could play the video, please. We are on bypass. This is the right atrium that you see. We've put the stay stitches on the pericardium, on the inferior aspect, and on the right atrium. We open the right atrium, as you can see, a transverse incision. Traction sutures so that we can retract the superior aspect of the right atrium. A lot of suction for the perfusionist. This is the cannula. You can see through the tricuspid valve, the white stuff is the fibrous reaction of the DC RV, double chamber RV. This girl had significant obstruction. The fibrous tissue is the reaction. We put a stitch there so that we can hold it to manipulate. There's a suction in there. We start cutting. This is the muscle bundles that are very hypertrophic, and the next to them is the reaction that has occurred from the turbulence and the jet hitting on the endocardium. It's a lot of tissue, obviously, as you can see, since we retract. We start seeing more of the RVOT now. a big piece has been removed. After all this time, and after this part has been cut, then we'll be able to see part of the pulmonary valve. Before it was not visible. More muscle bundles that are cut. You see how bigger the opening is of the RVOT right now. And that's the closure of the right atrium after the completion of the procedure. This is the periareolar incision at the end of the operation. And the two blade drains that we typically use afterwards. In the first follow-up visit, that was the image, and the final one was the last slide that I showed you before. Thank you very much for your attention.
Thank you very much, Mr. Mitropoulos. Does anybody from the audience wants to ask anything? Okay. Do we have Ms. Fanoula Papadopoulou to comment online?
Yeah,
Hi, Fanoula.
I'm here.
Hello. Hi, how are
Hello.
you?
Hi, I'm very good. Thank you for having me there. Sorry, I came immediately from theater, so unfortunately I didn't heard the whole presentation of Mr. Mitropoulos, but I saw the nice video at the end, and congratulations. I have a few slides just to, if I don't know if we can share that.
Mm.
Can you see those slides? Can you see it?
Yes, please proceed.
Yes, Fanoula, yes, you can see your slide.
Yeah, so people that they don't know me, hi, I'm working currently the last 2 years in Leicester Hospital, which is of course a university hospital, and we are being shared in two places. One is the pediatric, the LRI, and for the 16, 18-year-old congenital patients with acquired with congenital problems are in Glenfield. So for us, the setting is a little bit different. So the endoscopic camera is in Glenfield, and in small kids, we do have only the minimal approach if we are talking about. Just because it's been a teaching program, just to be sure that we do understand about what we are talking, is more than a decade now. There have been nice papers, and this is one whoever would like to read and see a few things, with a large number of patients of 396 with total endoscopic, but with conventional instruments, and predominantly is ASDs and VSDs. Either with patch or without a patch. And yes, as Mr. Mitropoulos very nicely pointed that overall the stay and the ICU stay and hospital stay might not be different. The only difference, of course, is a little bit on the timing in theater, but the team needs to be dedicated when we are talking about these patients. So not only the anesthetist and the scrub team, but the wider group also to be supported. So cardiologists to being willing to give the chance in this technique, because it needs to be learned, this technique, and sometimes the numbers are not being there, especially because our interventional cardiologists are taking a lot of the ASD group, so it doesn't stays a lot for someone in, at least with the volume in UK, to learn it quickly. So on that study, the peripheral cannulation was being for the venous 15 to 21 French as an average, and arterial 12 to 17. The weight of the patient was being 15 to 40 kilos, and there was a comparison with the conventional group, which that group, of course, was being much younger. The SVC was being through the third port cannulated with a small incision on mid-axillary line, and they had great results with only 14 of a huge amount of number, as I said, with intracardial residual SUNS, but you didn't have to go back and do anything. And this is also the experience of most centers. Now, this is another study that I want just to mention, because in difference now we are going towards to the right subaxillary ventricular thoracotomy, which we have tried, and it's in adults. I would say it gives a very nice view of the surgical field. And also you don't have the risk of violating the borders of the mammary gland. And this one, again, another study pre-COVID era. I don't know, there is a lot of questions about after COVID, how many centers, and everything comes pretty much from China, but from single surgeon performing all this operation. Again, another retrospective, but this one has a very large amount of patients as a number, 1,672, which now the mean age is 2.3 years of age. We don't have, of course, this kind of experience, and I have borrowed from that paper because nicely they demonstrated how the IVC cannulation to being out of the field, it comes down from the port, and that is the main table that they are sharing, trying to also expand to different type additional procedures. They're saying they have 13 different procedures, including the double committed subarterial. We are having experience only on ASDs. So just to summarize and have questions also regarding, as a perfusionist, what needs to think about, what we are thinking as surgeons. So we use end-to-side graft for the peripheral cannulation, and if there have been small, the arterial, the arteries, they have described that they can have bilaterally. We have never done it. Also, central cannulation in small children's, yes, we're doing, and always the IVC is with malleable. Sometimes the jugular vein cannulation is through the field if the anesthetist that we've got is not being trained, and I'm talking again from the adult perspective when we are operating. Any thoughts if it's been better for two stages and snare? We have never done it. Always we need a vacuum assist for venous drainage. What I want to say is that also now there is the new camera that is a 3D camera, and it's giving a very, very good images. with the 3D glasses. It's amazing. It's game-changing, I believe. And yes, I just want to highlight that only a fraction of the congenital surgeons, they had the experience and they are performing fully endoscopic, and most of us, we still need mentors to come in theaters. We are having the adult cardiac surgeons with the minimal invasive mitral, and also you need, as I said, very importantly, a supported team. Thank you.
Thank you very much, Fanula. Just Mr. Kotulas wants to ask a question.
Thank
Yes,
you very
please.
much for coming. Thank you very much for your comment. Just one comment. Why, Fotis, why do you prefer Del Nido and not the what is the name? Custodial as a cardioplegia? Because you have a longer cross-clamp time, so it's more safe to use the custodial one.
We have certainly used the custodial, and it's a very good cardioplegia solution. What we have found with the Del Nido obviously gives us 90 minutes, and if it's more than 90 minutes, we repeat. Custodial will give you up to 2 hours and maybe more. With custodial, we have found that you have less of a metabolic effect. We don't have acidosis the same way we have with custodial. The electrolytes are not as high as you have with custodial. And we have, in our personal experience, when we take the clamp off with Del Nido, almost never we have ventricular fibrillation, while with custodial, it's not very uncommon. We've seen that quite a few times with that. So,
just to give an idea, we prefer to give 1 liter of custodial when we are waiting for cross-clamp time about 1 hour, and to repeat the dose. And after when we are ready to remove the cross-clamp, we give blood.
Warm blood to flush it out. Yeah.
To flush everything out.
Yeah, we know that technique too.
So we have no problems. On the other hand, when we used the Nido, we have some problems. And I did not realize why. Because we had small cross-clamp time and no perioperative problems. That's why we moved to custodial. Thank you. And when we use 1 liter, we don't use any filter. Just 1 liter, and that's it.
Okay. Thank you very much, Fotis, for your presentation. So we can proceed to the next one, please. It's είναι ο Αυξέντης εδώ. Are you ready? Να περιμένουμε λίγο.
Δεν είναι ακόμα έτοιμοι ο επόμενος ομιλητής. Θα κάνουμε ένα μικρό διάλειμμα μέχρι να συνδεθεί. Okay. Hello. We are continuing now with Mr. Andreas Chodziski. Hi, Andreas.
Hi,
Andreas,
Nikos.
are you okay?
Very well. Thank
Andreas,
you very much.
Yes, it's Andreas Chodziski is a cardiac surgeon, consultant pediatric and adult surgeon in Royal Brompton and Harefield Hospital in London. I hope you are well, Andreas. Haven't seen you for years. Okay.
Yes, it's been a long time. Nice of you to invite me. Thank you very much for the invitation to you and your colleagues.
Okay. Andreas, you are going to talk to us about the congenital heart sensor in UK. That's right?
Yeah.
Okay. Thank you very much.
Okay. I hope this is going to work. I uploaded my slides to Melina. If you just go to the previous slides. Okay. So when Nikos and Christophorus asked me to talk at your meeting, I understood that this was mainly geared up to the perfusion specialists, but I wanted to give a little bit of a flavor about what is going on at this present time in the UK, what the current standards are, and some novel developments. So again, thank you very much for inviting me to speak. I currently work at the Royal Brompton Hospital, which is now merged with Evelina Children's Hospital at the old Guy's and St Thomas's site. We are now one very large pediatric cardiac center and large ACHD center, and we do, as you will see a little bit later, just under 800 procedures a year now. Next slide. So I will go very briefly through some statistics before I get to some innovation. So essentially, in the UK, what has been noticed over the last decade or so is that there has been a gradual decline in the number of surgical procedures done throughout all age categories. Next slide. And that's predominantly since the era of COVID, but has never really regained. Now, part of that will probably be due to the United Kingdom leaving the European market and more people moving back, but also due to changes in attitudes towards earlier repair and less staged repairs in certain conditions, but also due to novel technologies and interventions such as ductal interventions taking over surgery, for example. I won't dwell on too much, but overall, the total number in cases has increased, but this has been mostly due to overall interventions across all boards, not just surgery. We are now called Evelina London Children's Hospital, even though this takes in account Royal Brompton, Evelina Children's and St Thomas's, and the heart failure transplant service at Harefield Hospital. So we, as you can see, just under 800 cases congenital surgeries. Next slide. This is per year. Next slide. If you look at the mortalities, they're adjusted. As you can see, the mortalities are very good. In under 16s, we managed to get an overall mortality of under 1.6% for all comers under 16. Next slide. When we look at the effect of antenatal scanning and postnatal surgery, we can see that just over 50% of patients do get an antenatal diagnosis, more so in the very severe single ventricles like hyperplasts, where near 100% gets attained, but worryingly so in patients such as AVSDs, tetralogies, and transposition, that's still not mirrored, even though there is a better number. Next slide. So briefly, innovations in the recent year. There's various trials that are starting or are ongoing at the moment in the UK. One is a multi-site study involving all 7 pediatric heart surgery centers and ACHD centers in England, looking at various biological valve substitutes, which is a pure surgical trial. There's also a separate trial which is about to start, looking at percutaneous pulmonary valve intervention versus watchful wait and see in asymptomatic patients with severe pulmonary regurgitation, to see if there is a lifetime and clinical impact on right ventricular function and lifespan. And then there is also later on this year a new trial starting to look at a bioscaffold pulmonary valve in a transannular patch position, which can be progressively dilated to hopefully reduce the number of surgical interventions in due course. That's probably going to start multi-site in England in the summer. Another trial that's going to start is the use of Del-Nido in a randomized controlled trial across England. That's obviously a much more established cardioplegia strategy internationally, but not so much in the UK because of issues with licensing. But that is a trial which will start. Further prospective cohorts that are being looked at is PAIRS technology, which I will talk about in a minute, and in very limited numbers, limited access surgery takes place in pediatric and adult congenital heart disease in the UK. But I believe this is a topic that one of the other speakers will be speaking about. Next slide. So when we talk about surgical innovations, the 2 things that I want to just briefly highlight, which is, I guess, unique to the UK as it's kind of come out of the UK, but is now gradually being rolled out abroad, are PAIRS and ROS PAIRS. Next slide. Next slide. So what is PAIRS? Next slide. PAIRS stands for Personalized External Aortic Root Support, which was a technology devised by a biomedical engineer who was a patient with Marfan's who didn't want a root replacement and came up with an external support which was based on a computer model of his CT scan and stabilized the dimensions of his aorta, and by stabilizing it, it reduces the shear stress in the wall and therefore reduces the risk of dissection. The first operation was done just under 21 years ago in May by John Pepper, who's one of my adult predecessors here at the Royal Brompton Hospital, and this was essentially initially done for Marfan syndrome. Issues with that, next slide, are essentially patients with short left mainstem anatomy, severe pectus deformities, and they are more difficult in redo surgery. Here you can see in the left panel a patient I operated on with an aortic root and ascending dimension of around 55 to 57 millimeters. And you can see the yellow rubber sling around the left mainstem, which I've completely dissected free up to the ventricular arterial junction at the aortic annulus without the use of bypass. So essentially you need to dissect all the way at the bottom of the aortic root, have to go underneath the coronary arteries, which is all feasible. It is an operation with a little bit of a learning curve, but with adequate proctoring, this is a very useful adjunct technique to have for those surgeons who perform regular aortic root or complex redo surgery. And on the right-hand panel, if you click on that, you can see the technology, which is, if you like, an analogous to a Dacron porous mesh, which is computer manufactured specifically to this patient, which tightens up the dimensions. If you click on the right-hand video, and you can see then the graft in place around the aorta, and that stays as it is. Next slide, please. Next slide. Next slide. Melina, could you go to the next slide, please? Yeah, next slide. Okay. So what we've noticed over the last couple of years is that if you have patients who are starting to have aortic regurgitation, if you reduce the size of the aorta significantly, so you actually start correcting aortic regurgitation. So even though initially the thought of pairs was to just stabilize dimensions and reduce the risk of dissections and aortopathy, we started to think about how we can use this technology for other things, and importantly in our field of congenital heart surgery. So recovering aortic dilatation and with that improving coaptation of the aortic valve and therefore reducing aortic regurgitation and not having to give the patient a prosthetic valve is obviously an attractive option. Next slide. So this is the statistic a couple of weeks ago on the 3rd of January. These are all the patients that have had surgery. You can see in red those who kind of fit the more congenital remit. You can see that there's been 4 patients with aortopathy who had tetralogy previously repaired, 11 who had transposition and switches, who had neo-aortic root dilatation, who had pairs technology, and then those who had autograft dilatation and regurgitation that we've managed to recover regurgitation of the aortic valve and preserve the aortic root without replacing it. And then obviously there's plenty of patients of ours who also have bicuspid aortic valve disease with varying aneurysms in the setting of congenital heart disease. Next slide. This is patient number 1. This is just to illustrate the dimensional static dimensions over a 15-year period. So early after surgery, 2004, and then 15 years later, you can see exactly the same diameters. Next slide. What we've known from a patient late on who died from an arrhythmia unrelated to this surgery, about 4 years after surgery, he died of an arrhythmia, and the tissue was sent for histology. You can see that the material gets completely incorporated into the wall of the aorta, and you get neovascularization in the adventitia. You also see an improvement of the media, even though you still have in connective tissue disease, such as Marfan fibrillin deficiency, the wall thickens up, and therefore a reduction of dissection risk. And in fact, all of the patients who've had this technology and who've had the section of the root and ascending supported have not had a dissection in that segment over the last 20 years in the case series. There have been 3 dissections, to my knowledge, in patients who've had pair surgery, but in unsupported areas, so in the descending aorta. Next slide. As you can see, more and more centers in the top-hand graph are employing technology with pairs, and many more exponential patients are having this technology across the world exponentially. But the biggest takeoff has been over the last decade or so. As you can see, and not an inconsequential amount of those just under 1,200 patients who've had pairs technology used are under adult age. Next slide. So if you take this concept of pairs and external support and reduction into a different category of patients, where this is important, it's in the failure rate of those patients who have aortic valve pathology. And we've used it and called this the Ross pairs option. Next slide. So if we just look at aortic valve replacement in any age group, it's a common operation. There's a higher than expected mortality at 10 years after mechanical and bioprosthetic valves, as widely published. Next slide. You can see from French cohort that there is a significant reduction in bioprosthetic valve survival compared to the life expectancy. And the younger you are, the bigger that life expectancy difference becomes. Next slide. If you look at the top line being the Ross, the second, the red line being the mechanical valve, and the blue, the bioprosthetic valve, you can see that there is a significant difference in survival after the procedure at 15 years in those three, which favors the Ross procedure. Next slide. This is in a UK-based series. Now, if we briefly speak about the Ross, for those who don't know the ins and outs of it, next slide. It was devised by Donald Ross at the National Heart Hospital here in London back in the late 1960s. And just simply, you use the pulmonary valve, you excise the pulmonary valve and use that as an autograft. And next slide. And you use that in one of three main categories as a root replacement. So you get rid of the aortic valve and the aortic root, and you can either use it as a full root replacement. With coronary reimplantation, you can implant it underneath the coronaries as a subcoronary root, which was the original description by Donald Ross, or you do it as an inclusion root and reimplant the coronary arteries. And then you have to replace the pulmonary valve with, most of the time, with a pulmonary homograft. Next slide. To try and mitigate aortic regurgitation that we often see, and is the Achilles heel, or one of the Achilles heels of the Ross, various modifications have taken place. One is the full root, but including it into the native tissue of the patient. One is to stabilize the sinotubular junction with a short segment of Dacron tube grafting, and to also include the pulmonary autograft inside a Dacron tube, or to do a stabilizing annuloplasty at the base of the ventricular arterial junction, and at the ST junction also a little sliver of tube graft. None of them are necessarily without complications though. Next slide. The Ross kind of went out of fashion for about 2-3 decades, from the late 1990s onwards. But then El Hamamzi in North America popularized it again, the procedure. And this is based on New York State data, and clearly demonstrated that a Ross with that almost normalizes life expectancy compared to the other two options. It also reduces endocarditis and reoperation rates compared to biological AVR, and reduces stroke and major bleeding in those who obviously have to be on coumarin or warfarin derivatives in mechanical valves. But there's still an Achilles heel. Next slide. And that is reinterventions, both on the autograft, but also on the pulmonary homograft. Next slide. Next slide. So how to reduce the risk of autograft dilatation that you will get with all of those? If you employ the pairs technology to all of this, and you support the ascending aorta and the root at the time of implanting the autograft, and if you do have a degree of ascending dilatation or ST dilatation, you can stabilize all of that. You can see here the pairs graft around the autograft implantation, and essentially it becomes just an adjunct to a Ross. So next slide. So far over the last, I think, 7 years that we've been doing this now, just about 200 patients have had Ross pairs internationally. Having said so, probably about 2/3 of those, maybe 70% were done in London by 2 surgeons, myself, and a large proportion of those by my colleague, Conal Austin. But it's now progressively being adopted throughout Europe and also in the Southern Hemisphere. Less than 1% mortality for this procedure. Next slide. So it's all about choosing your patients. Would I still do a mechanical valve or a biological valve? Yes, I think if you have a much older patient or the pulmonary valve is mildly or more regurgitant, I think you have no choice. But you can modify your technique of the Ross depending on what your comfort levels are or what technology is available. And I appreciate that pairs technology is not available everywhere as yet. Next slide. Briefly, we have relatively standard protocols for temporary support with ECMO, both in children and adults in congenital heart disease. ECPR guidelines are now being published at the end of this year through the EACTS, together with various of the national societies, which we're currently writing. In pediatric cardiac surgery, limited access to transplantation is still there, and similarly for VAD support. Next slide. And that's it. So that's a brief overview over what is playing in the UK. Is there anything that anyone would like to ask me?
Andreas, thank you very much for your thorough presentation. I would like to wish you success in your difficult work, and I would like to invite Mrs. Aphrodite Gifa. She's
Hello.
the chief of the Department of Pediatric Cardiology and Congenital Diseases of the private hospital Mitera. Please
Thank you.
make us a brief comment on
Thanks.
the presentation.
Thank you, Mr. Chairman. Andreas, hi.
Hi, nice to see you.
How long has it been? Like 20 years?
Oh, don't say that.
So Andreas and I were co-fellows at Guy's and St. Thomas's at the Guy's side. So very nice to see you again. And thank you for the wonderful talk. It's very interesting that you focused on the pairs and the Ross procedure and the Ross pairs. We were very lucky through Guy's Hospital that we had a collaboration with Conal Austin. As you may know, Conal has a license to practice in about 17 countries around the world. So he also comes to Greece, and we did the first pairs here in an adult about 5 years ago. He was a marathon runner and had aortic valve regurgitation and a dilated aortic root. he was going to have a mechanical valve, as you said. And he said, I don't want to start anticoagulants, and I want to keep running, and I want to keep going to the marathons. So we got Colonel Austin here, and along with Fotis Mitropoulos, that was the previous speaker, they did a pairs operation for the first time here in Greece. And it's been 5 years, and he still runs the marathons. He was previously operated for double outlet right ventricle VSD, and he had a huge dilated aortic root. And then we went on to more patients. As you said, we did a TGA patient, adult TGA patient, and we did a military guy who was actually working abroad, and he was in very hard physical exertion all the time, and we did a pairs on him as well. And it is our experience as well that once the aortic valve dilates up, because the aortic root dilates up and you shrink it down, then the leaflets coapt better. And in all of our cases, we've had elimination or significant reduction of the aortic regurgitation, and it's like nothing has happened to them afterwards. So we are very, very happy with this technique, and with the collaboration of Colonel Austin. Now Fotis has picked it up as well. It's very interesting to say that this biomedical engineer who first invented this for himself still makes all the CAS, right? All the aortic root supports. He's still around, and he assesses and prepares through CTs that we do here in Greece, and we send them across to him in the UK, and he makes the personalized external aortic root support, and then Connell brings it with him from London, and we put it on our patients. The next comment here for us in Greece, Andreas, is what you said about the Rose procedure. And it's very interesting in an adult cohort of cardiac surgeons here to listen to the results from your series about the Rose procedure in adult patients with aortic valve disease, which is the worst disease to have. The aortic valve is difficult in children and adults. And we have significant kind of opponents here in Greece of the Rose procedure, not just in adults. I think in adults, I understand it totally, but in children too. So in children, the Rose procedure obviously is the only option we have, because we cannot implant mechanical aortic valves in growing children. And the opponents we have here in Greece, and I have to argue for the Rose all the time, is that you make a one valve disease to two valves disease. And when it comes to children, then we understand that there is no other option. But when it comes to adults, then to make a one valve disease to two valves disease, you understand that there will be significant opponents here to say, why do that? You just implant the mechanical valve. And the answer is your slide, that these patients, through the Rose procedure, even if they are in the adult population, they have normal life expectancy as compared to the adult patients who have mechanical valves and all the side effects of the anticoagulants throughout their lives. So it was very interesting to see these results and your slides. And after this, I only have one question for you. What would be your cutoff age limit for adult patients with aortic valve disease to offer them a Rose procedure in comparison with aortic valve mechanical aortic valve procedure?
So, thank you very much, Aphrodite. It's I think a very evolving area, but I have now developed a pretty firm view about my algorithm, if you like. I think up until, I would say 5 years ago, I would just use pairs for aortopathy, but I wouldn't venture into doing congenital heart disease pairs procedures because of the already difficult dissection, difficulty getting under coronaries, difficulties getting the if you like, in most of these situations, the RV outflow tract off. But having done some of those now, you actually, all of these things are a familiarity and a learning curve. Before I started doing pairs procedures 8 years ago, I didn't even think it was possible to do an operation like that. And then I realized when John Pepper proctored me that actually you can do this operation off pump. And it is all about familiarity and developing the comfort. Second thing to say is, as far as, you know, I've traditionally always had a very large ACHD practice. And I rarely have patients that come to me and say, I want to be on warfarin. Quite to the contrary, almost all of them don't want to be on warfarin because it cramps their style. They can't drink, or they can't have a headache-free lifestyle. They can't be as active. They want to have a life where they don't feel medicalized. It's easier when you're older to accept limitations, but when you're 20 or 30 or 40, that is a much more difficult psychological process to go through. And most of the patients, if they're insistent they don't want a mechanical valve, and it's a biological valve or a ROS, if they're not suited for a ROS because the pulmonary valve is not quite right, then I just put a biological valve in, which I do quite regularly in patients. If they are suited for a ROS, I think that is the superior operation. And it is all about choosing your patients right. If you have ventricular arterial, so annular aortic ectasia, you've got to deal with the annulus. You can't leave it like that, because even putting a pairs around it, you won't necessarily deal with the annulus, the ectasia per se. So I normally plicate it and then put the pairs around it. I do a reduction aortoplasty. So I tailor the whole aorta depending on the needs of the patients. But I do think it's a superior operation than the mechanical valve. It's certainly not the easier operation to do. It's really easy to do a mechanical valve, but I don't think the patient is necessarily served with that. Now, I completely buy the argument you convert a patient to a dual valve pathology, but I think once you get out of the learning curve, I constantly see patients being presented in the MDT here at the Brompton, patients who've been operated by Donald Ross, Magdi Yacoub, Daryl Shaw, who have 30, 35 years out from a ROS, an almost normal looking aortic valve.
And also the pulmonary homograph, there's been publications, and I don't know what your experience is, but I do transcatheter pulmonary valve implantations. What I see is that the patients, and we've seen it on publications, the patients who've had a homograph post-ROS within a ROS procedure, it seems that their pulmonary homographs last longer. So the freedom from re-intervention for the pulmonary valve is higher in comparison with other patients who've had homographs. So this is to be taken into consideration. And last comment about the ROS in women of reproductive age, I think we should say, because there's ladies of reproductive age, they want to have children, they can't or shouldn't be on warfarin. And so would you choose ROS as this choice of procedure in this population?
Yeah, absolutely. And I think once you attain a normal-sized annulus, as in normal adult-sized annulus, I mean, if you choose to do an inclusion ROS, I think it's probably equivalent, certainly in the setting of isolated aortic stenosis. I don't think that there's any suggestion that it's a better operation to do a ROS pairs over an inclusion ROS. But if you, for example, have mixed aortic valve disease or primarily aortic regurgitation, then you want to support that. It would be a mistake, in my view, to just leave it, because the chances that will dilate and you will get autograft dilatation and therefore failure within the first decade of your autograft and a reoperation is much higher. So I think in that situation, I would just support the root and the annulus.
But not all surgeons do the inclusion ROS because it's quite more difficult, isn't it? So we should argue for inclusion ROS rather than supraannular, right?
Well, I think that the subannular, I think, is more difficult to get right because you can get distortion, and it's not that popular. There is more surgeons doing inclusion routes or a freestanding route with modifications. Yeah, I think it's much more dependent on who has taught you how to do the Ross and how often you do the Ross, how well your results are. So I think, over the last 2 decades, there's been a real kind of decrease in volume internationally of patients undergoing Ross procedures. And I think this will start to pick up. We can already tell internationally that there is a real popularity regain of Ross procedures, not just under congenital surgeons, but also under adult surgeons. So I think with that, I think, there will be better stabilization techniques, better longer term outcomes. And I think because of that, patients will be better served.
Thank you so much. Thank you.
Thank you very much, both of you. I'm afraid we're running out of time, so we have to proceed to the last presentation. Dimitris, please
yes, of course.
Address the
Can
next,
I ask last question, Andreas?
Of course.
If you have a patient with less or minimal or medium aortic regurgitation with dilatation of the aortic root, you will prefer Pearl's procedure for this?
Over a valve sparing route?
Over the others. I mean, Jakub or whatever.
I think nowadays, if there is no leaflet pathology, I think it makes no sense to me to be replacing the aorta. You achieve the same thing. I think I used to do David procedures. I wasn't very good at, I never got taught how to do a Jakub, so I preferred the David 5. And I had good results with that. So I used to do, for example, truncuses with dilated roots or other congenital pathologies, failed autografts. I did valve sparing roots on. But when I learned the PAIRS technology, I realized that I can achieve more without being invasive. And I think it's a matter of just familiarity. It is an intimidating operation to start off with, but you learn very quickly that you can do that. And I think the results are equivalent, if not better, because you don't touch the leaflet, so you don't have the risk of distorting things.
Okay.
So I think
your preference is the best.
You have to have symmetrical sinuses. If you have asymmetrical sinuses, you have an asymmetrical valve, then it's much more difficult to get a nice result. So you do have to tailor it slightly.
Okay, thank you. So we can proceed to the next, please. Is Dr. Avxenios Kalagos, is director of the cardiothoracic clinic of congenital cardiac disease in Euroclinic of Athens, and he's going to talk about performing pediatric cardiac surgery in developing countries. So, Dr. Kalagos, you may proceed, please.
Good evening, everybody. First of all, I would like to thank Dr. Koutulas for his kind invitation to present the humanitarian pediatric cardiology and cardiac surgery in low and middle income countries. Thank you very much, Dr. Kroupali, for being online with us and for your comments after my presentation. Now let me start with the definition of low-income country. As you see here, there is a very, I will say, efficient index defining the low-income countries, which is the Human Development Composite Index related to the life expectancy, educational level, and also to the economic power or quality of life of a given country. if you see the map of the world, only 20% of the world global population live in countries with HDI superior to 0.7. It means the rich countries, the developed world. 30% of the population live in borderline countries with middle income, and the HDI index is between 0.5 and 0.7. And as you see, 50%, the remaining 50% of the population live in countries with HDI index inferior to 0.5, which is the definition of the low income. Compared to the more developed countries, in less developed countries, you see the demography of the population. There is more young people who are more, I will say, vulnerable in terms of diseases. And in the more developed countries, as you see, the distribution of the demography has the shape of an ellipsoidal shape. There is a homogeneous distribution between male and female, and between young and middle-aged and elderly people. There is another factor regarding the world population, especially regarding the people less than 18 years old. As you see here, more than 50% of the population are made of young people, less than 18 years in this country is represented by orange color. And 85% of this young population live in low-income countries, which represent around 2 billion children. Now, as you know, there is some indicators which is in relationship, close relationship with the health condition. And in low-income countries, despite all the efforts and all the money invested for the improvement of the conditions, there is, I will say, a very small improvement regarding the life expectancy at birth between 2000 and 2010. As you see, again, there is a small decrease in infant mortality, a small decrease in mortality under 5, and also an increase in measles immunization. It means things that are not going as we are expecting. There is also some parameters to determine the needs in cardiac surgery. As you see, these 3 parameters are very important, especially the first one is the number of open heart surgery cases per million of inhabitants per year. The second parameter is the number of cardiac centers per million of inhabitants. And the third one, the number of cardiac surgeons per 100,000 inhabitants. Let me start with the first one. If really you would like to cover all the needs in terms of open heart interventions, the country has to be able to perform 860 cases per million inhabitants per year. If you have, this cutoff value, and if you see a little bit the distribution of open heart interventions, the best results belong to North America with 1,222 open heart interventions per million inhabitants per year. Then Australia, then Europe with around 600 cases per million inhabitants per year. And then if you go to South America, the results are getting worse with 147, Russia 37, Asia 25, and unfortunately the final position belongs to Africa with 18 cases per million inhabitants per year. Regarding the second parameter, the needs in terms of cardiac center, again, the best situation is in United States with one specific center per 120,000 inhabitants. In Europe and Australia, there is one center per 1 million inhabitants. In Asia, one center per 16 million. Again, the final position belongs to Africa with one center per 33 million inhabitants. It means that 4.5 billion of people have no access to cardiac surgery outside of North America, Europe, and Australia. Regarding the last parameter, the number of surgeons per 100,000 population worldwide, again, the best numbers are from United States, 51 cardiac surgeons per 100,000 inhabitants, then Japan, Canada, Australia, Germany 13, China 10, and then in Latin America 7, and if you go again to Africa, this number is going down. Now, one of the other additional problems the low-income countries are affording is the brain drainage. And especially I was in 2007 in a regional, I was attending a regional conference in Nairobi, and there was a lot of cardiac surgeons and cardiologists. And I asked this question, why, they would like to leave their country. And among this 100 surgeons, only 21 have the courage to reply to my question. And as you see, 38% of this respondents wanted, to leave the country. And if you go and investigate a little bit the reasons, in 65%, it was due to financial conditions of the country. 24%, they wanted to have more training facilities. 1% political, and 1% was not satisfied by the job. What is now the situation? I'm mentioning this one, the brain drain, because is a real problem, especially in the low-income countries where there is no highly qualified medical and paramedical human resources. As you see, approximately 10% of physicians in high-income countries come from low-income countries. And especially for some African countries where our foundation has humanitarian missions, we realize that this equals 30% of their health workforce. 60,000 professionals, medical professionals, emigrated from Africa between 85 and 90. And there is 20,000 professionals immigrated since then. Again, if you see a little bit the statistics of United States, you will see that there is 21,000 Nigerian doctors, and 60%. The situation in Ghana is really very dramatical, because 60% of the Ghanaian doctors trained since 1980 have left their country. As I told, the brain drain has a cost for low-income countries, but benefit from high-income countries. For example, in UK, they estimated that they saved 120 million pounds in training costs between 1998 and 2005 by recruiting only Ghanaian health workers. Again, there is another report published by the United States Congressional Research Service between 71 and 72. And for each professional medical migrant, the United States gained $20,000 per year dollars. In the United Nations Conference on Trade and Development in 1979, there was a very nice presentation and making an estimation regarding the cash value of an African medical professional migrant, and this value represents $184,000. Unfortunately, this one, as you see, all these numbers can easily show what the low-income countries which have restricted human resources, they are losing on a yearly basis. Now, regarding the current situation in low-income countries with regard to cardiac diseases, especially there is two categories. The first one is, as everybody knows, is the congenital malformations, and the other one is also a real social problem, the rheumatic valve disease. Let me start with the congenital malformation. Everybody knows that the incidence is fluctuating between 4 and 12 cases per 1,000 births alive, which represents between 12 and 36 million children with congenital malformation. And unfortunately, half of them will die of the consequences of their cardiac diseases, infection, malnutrition, and some of them will be inoperable. And for the other 50%, I believe there is something to offer. And as you see, this number is not a small number, is between 6 and 18 million children suffering, who are continuing to suffer with from congenital malformations. And this one, there is another reality that there is every year 130 million births in the world. And as we know, the incidence of congenital heart malformations, you can easily calculate that there is an additional amount of number between 500,000 and 1.5 million neonates born with congenital malformation who will be added to this total number every year. Regarding the rheumatic valve disease, if you look at the statistics of the World Health Organization, the incidence is 0.5 per 1,000 children, and globally I can tell that 1% of children, especially in Africa, suffer from this disease. At least there is 12 million people across the world who are involved. 2 million children need repeat hospitalization, and unfortunately, again, based on the statistics of the World Health Organization, there is 500,000 deaths per year. And 1 million people, and especially children, need valve surgery. To make things a little bit more clear, I wanted, to show this one, because if you have a population of 10 million, and if you would like really to start a humanitarian project, you have to know that there is 20,000 children suffering from congenital malformations and 5,000 children from rheumatic valve disease. It means there is for a country, for a low-income country of 10 million inhabitants, there is 25% children who need cardiac surgery. For example, if you go to Vietnam, where our foundation has a program, you have to multiply this number with 10 because it's 100 million inhabitants. In Mozambique, where we have also a humanitarian program, 20 million inhabitants, it means there is 50,000 children who need cardiac surgery. Now the question will be, how to solve this problem and what is the ideal long-term tactical plan and model. And to summarize, because usually when I am presenting the humanitarian pediatric cardiology or all this humanitarian project, they are asking me if really the humanitarian project can be sustainable. I can tell you they can be sustainable if there is a very strong commitment from the side of all the actors, stakeholders involved in the project. Here above you have, the NGO or the international organization. In the middle, you have the project, and on the opposite side, you have the host country. The mission, the essential mission of the NGO involved in a humanitarian project is to provide education and teaching, clinical and research support, and some kind of administrative and logistical support, and a lot of financial support. I will say, endless financial support, and for this, you have to get financial partners to make the project sustainable in long term. But on the other hand, the host country has also, I will say, a lot of obligations because they have also to contribute to this financial aspect. They have, to provide political support. In the past, in some countries, I had also some project which failed, and then it was related to the lack of political support. And you have also to get also the contribution from the host country regarding the clinical and research support, present, the right candidates, the right human resources to be trained by the NGO or international organization. Now, regarding our humanitarian experience, which started in Geneva in '95, I started establishing a collaboration with the humanitarian NGO Terre des Hommes, and in '98 we started our humanitarian missions in Eritrea. And just, after the first mission, we founded the Humanitarian Association Cœur pour Tous in '98, which was later on integrated into Kalangos Foundation in 2014. Again, I would like to show some sustainable project. For example, in '98, we started in Georgia. Now the center is completely independent, and they continue to offer their services not only in Georgian children, but even in children coming from Armenia, from Azerbaijan, and so on. Again, '99, Mozambique, we set up the Pediatric Cardiac Surgery Center, Instituto de Coração, in Maputo, in the capital city. It was a project which was realized by the close collaboration of 4 NGOs, including ours. And the center also is completely independent now. Again, another successful project in Mauritius. We started in 2000, and we set up the cardiac center. And not only, they are offering their services in Mauritian children, but they are also on a yearly basis. They are receiving a lot of children coming from different islands of the Indian Ocean, Madagascar, and so on, Kenya, etc. In 2003, Serbia, after especially the bombardments of NATO, there was a difficult situation for the country. And during the spirit of time, we provided a lot of help. And finally, in 2003, we set up a good unit over there, which is highly functional now. And they trained also a lot of pediatric cardiologists and pediatric cardiac surgeons. And I can tell that they are able to treat surgically more than 90% of their local cases. Again, in 2005, another sustainable project in Vietnam, in Saigon, we signed a convention, a memorandum of understanding between the University of Ho Chi Minh and the University Hospital of Geneva. And in this project, we put also the Ministry of Health because we wanted to have also the political support from their side, and it was a very successful project. And now this university, this Department of Cardiac Surgery in University Hospital of Saigon performs on a yearly basis more than 1,500 surgeries per year. Again, another nice project in 2006 with Cameroon, especially thanks to the close collaboration with the foundation of Chantal Biya, the First Lady of the country. Again, another collaboration with the University Hospital of Geneva. And later on, again, a good project in 2017 in Yinchuan, China. Especially this project was, to improve a little bit the educational level in pediatric cardiac surgery at Carver Heart Center. And we signed a memorandum of understanding, and I continue to have a telemedicine program because there is now two very good surgeons covering the whole needs of this province. After having showed all these sustainable, beautiful projects, I would like also to pay tribute to the former Vice President of United States, Mr. Al Gore, because thanks to the contribution of his foundation, he helped us to set up many programs, especially in South Asia. And I would like also to pay tribute to Bernard Kouchner, the founder of Médecins Sans Frontières, Nobel Prize, former Minister of Health and former Minister of Foreign Affairs of France, who help us to set up many projects in Africa. Now, regarding the humanitarian actions and projects, we are in 20 low and middle income countries, initially through Hearts for All and then Kalangos Foundation. There is more than 20,000 children who were treated since 1998 by surgeons and teams trained by us in all these countries where we were involved. And especially, I would like to show you some of them from Georgia, Cameroon, Azerbaijan, Mauritius, Albania. As you see here, there was around 72 surgeons, pediatric surgeons, anesthesiologists, pediatric cardiologists who were trained thanks to the scholarships given by the Kalangos Foundation. In 2003, we started organizing the humanitarian forums in cardiology and cardiac surgery every 2 years in collaboration with all international organizations, especially with the World Health Organization, the World Heart Federation. And this year in November, we will organize the 15th Global Humanitarian forum in Bangalore, India. Again, we started in 2019 the edition of the Journal of Humanitarian Cardiovascular Medicine. Up to now, we received more than 40 articles, and the responsible, the editorial manager is Mrs. Futini Kirici, who is doing a wonderful job. I would like also to pay tribute to her. Last year in November, we reactivated the project of Global Heart Network. The Global Heart Network is a foundation, is an American foundation according to the federal law of United States. We founded it in 2011 in Delaware, and it was created to improve especially the provision of cardiac care in middle and low income countries. Between 2011 and 2016, we tried to develop the technology for organizational and program efficiency for all stakeholders working in the humanitarian field. But it was very difficult, and for that reason, you know, we started providing more heart care to children across the developing world, referring them to Geneva and other centers. But thanks to our recent collaboration with the Sri Sanjivani Foundation in 2024, we have started establishing this humanitarian platform to achieve our initial goals. If you have, you know, some interest, you can go, you have the website, you can, if you are a physician, you can register yourself, and you can check everything this platform is able to offer to the children across all the low-income countries. As I told you, know, there is this Global Heart Network, especially the platform we set up, has three essential missions. First, to connect independent efforts and initiatives coming out from different stakeholders with people in need via a collaborative platform. The second one is to improve the provision of pediatric cardiac care in middle and low-income countries. And the final one is to organize and coordinate all the humanitarian actions. You see, it's a very ambitious project, this one, between the different stakeholders. Who are the stakeholders? As you see, there are multiple NGOs, hospitals, networks, World Health Federation, humanitarian journals. There is the industry, because some of these companies, they have also foundations providing free of charge material to low-income countries. The national health authorities, especially the health ministries, the World Health Organization, the scientific societies, and there is also some kind of individual efforts coming out from some cardiologists and cardiac surgeons involved in sporadic humanitarian missions. Now, this one is what we achieved. We created the centralized structure of the platform. As I told you, there is 16 million children waiting for surgery in the developing world. And as you know, even you know, in the rural areas now, you can easily find out a laptop, you can get access to internet, you can make an application for an overseas free of charge treatment. You can upload the heart care records, investigation, imaging, and we receive all these things because we have a committee, a team made of cardiologists, pediatric cardiologists, and cardiac surgeons at the Global Heart Network, who screen all these medical files, reports, investigations, and they decide if the child is inoperable. We organize the treatment with the local medical and paramedical counterparts. If the child is operable, we transfer to the closest humanitarian cardiac center for surgery or treatment. One of those centers where we will be able, to refer those children will be the International Center of Humanitarian Medicine in Silivri, Istanbul. Again, this one is an ambitious project in collaboration with Divine Will Foundation from United States. And all these efforts are focused on this 16 million children, especially waiting for a last hope, I will say. And I would like also to finish with this great American philosopher, Joseph Addison, who once told the grand essentials to happiness in this life is something to do, something to love, and something to hope for. Thank you so much.
Professor, thank you very much for your detailed speech. You are doing a remarkable work. I would like to invite Mrs. Dr. Krupali from Fiji Island. Are you Fiji or Canada?
Fiji.
Hi. Fiji. Dr. Krupali is the director of Sai Sanjivani Children's Hospital in Fiji, who is they have a heart center there for children and for the children of Fiji and the South Pacific. We personally met last September. It's an honor to have met you. Hi. You want to comment on Mr. Kalangos?
Sure. Thank you so much for this invitation. Truly honored to be online today. Thank you, Professor Kalangos, for a wonderful presentation. And it's very close to my heart because you're talking about, pediatric cardiac surgery in developing countries. And I think from your presentation, it's very evident that there is a real need to assist the children in developing countries, and that the burden of congenital heart disease and rheumatic heart disease, especially in the developing world, is still very high. And there are many gaps. But it's really heartening to see all the work that is happening. So I congratulate you, Professor, for all your work with your Kalangos Foundation and now also with the Global Heart Network. And for me here in Fiji, so I'm the director of the Sri Sathya Sai Sanjeevani Children's Hospital. We had the pleasure of having Professor Kalangos and his team with us in September, and they operated on quite a few children with congenital heart disease and also rheumatic heart disease. Many of you may not really be aware, but till we built our hospital and it opened in 2022, we had no hospital in Fiji or the Pacific Islands that was able to assist these children. And we have at least 200 children born every year in Fiji and about 2,500 children born in the South Pacific Islands. Our hospital provides free surgeries. There is no billing counter, but we rely on the support and the generosity of many people and specialists and surgeons like Professor Kalangos from different parts of the world. So we do have visiting teams that come almost every second month. We've done about 351 free heart surgeries so far and over 25,000 echocardiograms. Our hospital was built also, so the government of Fiji granted the land to us. I work with Sai Prema Foundation, and that's the NGO that I work with. However, it was a $25 million project, Fijian, which is about 13 million US dollars. And all of this had to be funded by us as a foundation. We worked with a lot of people from different parts of the world. But what I would say, Professor talked about, working the politics of it, working with the government and the Ministry of Health. And I think in Fiji, what we are doing as an NGO, we have built this hospital and we've equipped it. And we really kickstarted the project. But I'm happy that the government is now supporting us as well. They're providing us with a small grant. But more than that, when we have surgeries happening, we have the medical professionals, the doctors, nurses, and some medical professionals coming from the public hospital to work with our visiting team. And we as a hospital have also employed some of our own nurses, biomedical engineers. We're working on recruiting a cardiologist. And of course, we will look forward to training a perfusionist as well. And, you know, it's only been 2 years. It'll be 3 years in April for our hospital. But a lot has happened. But we know that it's a very steep curve. We still really need to work on building local capacity. But I'm really happy that we have some nurses that we're already training. One of our nurses has gone to India for further training at one of the hospitals, the other Sanjeevani hospitals. So I think that the future is bright, although there's a lot more work that needs to happen. But many of our children who would have died, you know, have had the hope and have had the opportunity to have surgery. So I'd say that it is possible. It's not easy. It is very challenging. But I'm really happy to say that, you know, we have a center in Fiji that caters for not just Fiji, but also all the South Pacific Island countries. So thank you, Professor. And also thank you, Nicholas, for being a part of the mission that you were here. You operated on some children who are quite complicated. You gave them hope. And I think that really is important. And that's really what it is, isn't it? It's that hope. And, you know, when you see these parents and you see these children after they've had their surgery, you know, you can just see how happy they are. And many of our parents and our children here didn't have that hope. And because of our hospital and because of the work that's happening now in Fiji and the Pacific, I would say that it's been an incredible, 2 years. We've had teams from Australia, New Zealand, the United States, from Singapore, from India, of course, from Greece and Turkey, from Professor Kalangos' team. And we very soon, just next week, we have surgery starting and we'll have the Singapore team coming. So Professor Kalangos, I congratulate you for all the work that you are doing. And I look forward to, seeing you again in our hospital. And I really hope, and I'm sure that this Global Heart Network is really going to change and transform the lives of millions of children around the world. So thank you very much for this opportunity.
Thank you very much for being with us. Thank you.
Thank you.
Thank you very much, Dr. Tabu. You are doing an amazing work there, and all the logistics there that you have. When I went there, it was everything was amazing. I couldn't believe like moving all the people, and you had all the disposables that available, many choices. That it's almost amazing the work that you do there. Okay, thank you.
What time is it in Fiji now? She didn't hear. Okay.
Should be. It's 7:23 in the morning. Okay. Thank you, Professor Kalangos.
Thank you so much, Nikos.
Thank you.
If there is any comment or question. So this is the end of the second lesson.
I have a comment.
Okay.
I have to focus on your first talk, Dimitris. So because it's a congress, congress with extracorporeal circulation management, it was amazing that this I want to say is if you notice the talk of Dimitris and have 5-6 points for pediatric perfusion management. So if you are going to focus in these 5 things, you are going to have, I'm speaking about for the departments that they are performing pediatric cardiac surgery. So these 5-6 points that you mentioned, it's the alpha and omega in perfusion support. So that's I want to say for the management in with focusing in perfusion management. Thank you for that.
Ευχαριστούμε τους ομιλητές για τις παρουσιάσεις τους. Ευχαριστούμε όσους παραβρέθηκαν σήμερα εδώ, όσους ήταν κοντά μας και όσους μας παρακολούθησαν διαδικτυακά. Σας περιμένουμε στο επόμενο μάθημα στις 26 Φεβρουαρίου του 2025. Σας ευχόμαστε καλή νύχτα και καλή συνέχεια.